Good evening, everyone, and thank you for joining us. My name is Carver. I'm a product specialist here at Oculus, and welcome to tonight's clinical webcast, Managing Dry Eye in the COVID-19 Era. You have a text box on your GoToWebinar screen where you can enter in questions. Enter your questions at any time, and we will discuss them at the end of each speaker's presentation. We were lucky enough to have two speakers tonight. First is the renowned Dr. Paul Karpecki, the clinical director of the Advanced Ocular Surface Disease at the Kentucky Eye Institute. He is the chief clinical editor for the Review of Optometry and one of the foremost experts on dry eye. He'll be speaking about the impact of COVID-19 on treating dry eye. Second, we have Dr. Tony Giannotti, a vision source doctor who has practiced optometry for over 40 years. He'll be talking about how even if you can't purchase all of the expensive dry eye treatments, the ability to diagnose dry eye properly is essential for improving the care of your patients. I'm so excited to learn from you both tonight. And now, Dr. Paul Karpecki.
Thanks, Carver. Wonderful introduction. I'm honored to get to join Dr. Giannotti on this presentation. Our presentations actually flow really well together in terms of, it's true, you really have to have not a minimalist approach, but you really have to have enough information to make the right diagnosis, especially in today's COVID era, because we are limited in terms of amount of time we can spend with patients and how we do our testing. You know, if you think about this past year, it's hard to believe it's been exactly that, a year and about 3 weeks since things have closed down. But it seems like things are finally starting to move forward and vaccines are happening and we're getting closer. Numbers are coming down in most parts of the country, not all. But COVID era, really, those clinical practices we had to do are not going to change, unfortunately, because I think the last place you're going to see changes in are going to be medical offices, and optometry offices obviously fit that very well, because we're going to have to maintain our protective equipment. We're going to have to maintain distance when possible, minimize time with patients. Studies show that you can actually spend about 15 minutes with a patient if you can get to the extremes of your lane, like about 6 feet. But if you're within a foot, you should maintain no more than 1 minute. Some studies have shown up to 2. But that's obviously being very cautious. That's obviously with PPE. But at the same time, I think it allows us to practice at a pretty good level. Now, gloving is not going to go away. Slit lamp shields will be there, even though I hit them 4 or 5 times every morning, every afternoon. Masks, we're going to be masked. The staff are going to be masked. Patients are going to be still asked to mask. We're going to have to clean before and after each patient. And, you know, and that double cleaning does seem to look good to the patient too. But the key is we're going to have to have quick exams, which we've had to do in the last year. And you got to hand things off to someone else who will then take it from there, who follows the same COVID guidelines. In a way, it kind of fits into this type of technology, though. The imaging is helpful for distance efficiency, diagnostic accuracy, allowing you to make a proper exam without having to bring the patient back 4 or 5 times, or not sure of the exam and having to bring them back, or not sure of the outcomes or the results. So the technologies do play a role. Yes, you can do some things simplistically, and I think that's important. And no matter what, you have to manage dry eye disease. But I do think technology continues to play a key factor. Now, one of the most important things I can impart, I've been, you know, my first dry eye clinic actually started 24 years ago, hard to believe. It was kind of futile, to be honest. We really didn't do all that well back in 1997. I would say that many more than half the patients that I saw, probably 75% of the patients at the time, would be saying things like, is there another doctor that might be able to see me? You know, can you imagine working where 1 out of 4 people think you have no clue what you're doing? Today, I will tell you, we probably have about a 97% success rate, and our patients are the very worst that get sent in from all over. So it just shows what has changed. One thing that has really saved me a lot of time is realizing the importance of eyelids. And it's not that I realized that I had to rely on people like Don Korb and others who really knew this stuff incredibly well, who were kind enough to share insights with me that I could then incorporate into my practice. And so, but if you know this, it really saves a lot of time. You could do most of your eyelid assessment in less than 20 seconds, and it's critical to dry eye disease. Let me give you an example. Here's a patient who presents with blepharitis, but it's not overt. I mean, it's not in the lashes. And I'm not showing the upper eyelid, which is very similar. But if you look closely, you see a lot of things. One, you see that at the base of the lashes, there are collarettes. And in some cases, there's just this volcano sign where meibum and bad, or more biofilm, actually. It's more bacterial biofilm. Sometimes the collarettes are Demodex, of course, that play a role coming out of the lash. You can see capped glands. So we know there's some MGD level. You can see telangiectatic vessels. So really just knowing what to look for helps you a lot. Probably some ocular rosacea, Demodex blepharitis, and severe meibomian gland dysfunction. So you can get a good idea just by looking at it. But I've had patients where I expressed the meibomian glands and nothing came out, and their meibography was perfect, and other patients where I expressed the meibomian glands, nothing came out, and they had no glands. So having technology helps, but you have to start here. You have to tell patients to look slightly down to be able to see if there are collarettes at the base of the lashes, which is classic for Demodex, as you all know. And optometry has been on top of Demodex for over a decade. We really have, kind of led the understanding of this disease because we've had to as seeing these primary care patients. So this isn't new to many people, but it's a good reminder. Demodex really requires a much more targeted treatment. Low light level therapy, tea tree oil, in the future TP03, blepharoexfoliation works well here. You have to express meibomian glands. You can't get away from this simple thing. It only takes 5 to 10 seconds. You put a paddle behind the eyelid and you press on it to see what comes out. It should come out like olive oil. It shouldn't come out gelatinous like this or paste-like or non-expressive. Then meibography, it really does help you to know the level. If I had a person who lost 50% of their glands, I'm going to treat them very differently than someone who looks like this, where all the glands are present, even though I can't get expression. This is the patient that I have to be much more aggressive in. I just don't have many glands left. What's amazing, though, according to work by Korb and Blackie, is that you only need about 5.5 glands to be asymptomatic. So you don't give up on a patient who here has maybe 5.5 glands, yeah. So, but at the same time, you have to be able to diagnose that, to know that you can't let anything else atrophy here. We got to ensure that we're going to manage this patient very aggressively. You can see very few glands remaining. So combining technology is good. The good thing about in the COVID era with having technologies like this is someone else is doing the testing. They're not going to be exposed very long either, because the patient, this is a quick exam, quick testing, quick capture, and then you have time to look at it and then go through things with the patient. My diagnostic protocol has really changed over 20 some years. I really don't even use a questionnaire all that often, but I would encourage it if you're in a primary care setting to ask very directed questions. I do test osmolarity. I think meibography is critical. I like to look and see if the eyelids close properly, and I do a really good exam like we just talked about to look at the eyelids, conjunctival chalasis, express the meibomian glands, and I use fluorescein dye. I don't use lissamine anymore just to save time. I need to get my exam down to about 3 minutes for dry eye, and this is truly a 3-minute exam. The dye helps me look for staining. It helps me with a rat and filter look for conjunctival staining as well as corneal. I can look at the tear meniscus, and I don't sit there and time the tear breakup time. I glance at it, get an idea that it's quick, and that's enough, and that's sufficient. Osmolarity is a valuable tool if you're going to be in a dedicated dry eye clinic. It's one of the most accurate tests we have if technicians know how to acquire it. The measurement's actually on the bottom of the reader, on the little tip. Most people think you poke the eye with the end. That'll just create a epiphora. You got to set it on top of the tear meniscus. And when you do, it's really the most accurate test we have. But I don't think if you're in general practice and you're not focused specifically on dry eye, that you necessarily require it. I think you can get by with just looking at staining and a quick breakup time and expressing the meibomian glands and looking at the tear meniscus. And we're going to go through that because there is an algorithm or a protocol that goes into this. Before I do, I want to go over that KB test. If you have a patient who complains of morning symptoms or overnight symptoms, who has inferior corneal staining, a real quick 1 or 2 second test is you turn the lights off, you grab a pen light or better yet a transilluminator, you put it just above the tarsal plate and you look at the bottom for a beam of light coming out. That tells you you have incomplete closure. Remember, our eyelids are more like our teeth. One seals over top of the other, not above and below. So I tell patients, you got a little bit of an overbite, and that's why you're getting this issue. Often age plays a role, but some people like myself are born with that. I have that in my left eye. It's pretty significant. My right eye never developed it. I don't know why, but I have a really big gap on mine, and that's always the eye that's had recurrent erosion and issues. So you would see mine readily, but it really helps. Also, gauging redness, which you can do, again, with the OCULUS Keratograph. I think it's important, though, that you get good at doing expression. There's a few seconds. I place that behind the eyelid. I press with my thumb on the outside. Today, my thumb would be gloved. This must have been from past a year ago. And I look to see what comes out of the glands. Obviously, that's toothpaste. That's not quality oil. We have some meibomian gland dysfunction. You know, you look at that and think, well, that seems so simplistic. Are you sure that's very scientific, Paul? You don't really have a lot of science. It's just what you've done over 24 years. Actually, it's the TFOS due to diagnostic methodology algorithm. You start with some triaging questions. You look at risk factors. You do a questionnaire, which is symptomatology. You then do one of these 3 tests: breakup, staining, or osmolarity. Hey, there we talked about doing that. Next thing after that is you know that you've got dry eye. You can do all this with the Oculus, which makes it even more efficient. There's your breakup time. I have a pretty good idea that that significant drop is in a few seconds. We know that's a severe level, and we can also graph this to see what happens over time if we're improving the patient. I could look at corneal staining. Again, I could just use the Keratograph, or I could have my staff put a little fluorescein in and I look at it with my Ratten filter at the slit lamp. I can grade the changes over time or grade the amount. Then once I know they have dry eye, that's the only problem with those 3 tests. Osmolarity is high in any type of dry eye. Staining can be present in any type of dry eye. Breakup time is fast in any type of dry eye. You then have to determine what type of dry eye it is. And why that's important is because your treatment will be different. If it's an evaporative form of dry eye caused by meibomian gland dysfunction, the best way you would know that is your meibography off of Oculus and your expression, which we just talked about. If it's an aqueous deficient dry eye, that's your Sjogren's, your KCS. What does the TFOS-DUES-2 diagnostic methodology suggest you look at? Well, that's the tear meniscus height. And I don't honestly measure it. I don't say, okay, it's 0.2, 0.1, but you could do that with the Oculus Keratograph. That's what's great about this technology. But I've just gotten good at knowing what normal looks like. And you'll get good at that too. I mean, everything you do, when you look at injection of an eye, you know what normal is. You don't necessarily, have to have a whole bunch of scales to tell you that's not normal. And same thing with the tear meniscus height. You'll know that it's very scant by looking at a whole bunch of normal contact lens wearers who have the adequate tear meniscus height. So everything I just went through, you just saved 77 pages of reading. That's how long the diagnostic methodology and the TFOS-DUES-2 report is. This was my committee that I was on. I wasn't chair, I was just one of the members, but it was a great committee to be part of. And ultimately, it came up with a pretty cool diagnostic algorithm that's kind of similar to what I've been doing for a while, but even better than what I was doing. So here's your expression. There's your tear meniscus height. All of the systems can be done in this Keratograph M5, which is great. Now I've made a diagnosis. So I know the type of dry eye. I know they have dry eye. And remember, to have dry eye, you need symptoms and you need signs. So either you ask directed questions or you use a questionnaire. And then, like the TFOS-DUES-2 recommended, you look at either breakup time, staining, osmolarity. Now we know it's dry eye. We need to know which type. We express the meibomian glands and look at meibography. And if they're abnormal, that's the evaporative type. If that's all normal, we look at the tear meniscus. If it's really scant, that's the aqueous deficient form of dry eye. And of course, you can have a mixture of the two at times, making it a little more complex, but most times one is dominant. Then you educate. The best way to educate is to show them their own pictures, to be able to say, hey, this is your eye. Fortunately, got wonderful meibomian glands. That allows us to address this condition a little more conservatively. If you were down to your last 5.5 glands, then I would be throwing the kitchen sink at you to keep you from losing any more. But because you have so many here, we can begin in a more conservative manner. So my algorithm for treating evaporative dry eye, this is meibomian gland related. That's why expression is so important. That's why meibography is so important, is to treat all the elements of this form of dry eye. That's the obstructed glands, the blepharitis, which is typically there when you have MGD. Not always, but I would say 90% of the time. Inflammation and tear film. Well, guess what I did 24 years ago? I treated the tear film. So I would, take a look. That's all I would treat. I wonder why the patient never got better. Today, I'll look at the meibomian glands. I'll grade where the patient is. I'll show them what the scale is. And then I'll say, here's where you are. And I can tell them exactly where they're at. And they love that. Say, oh, I'm here. Oh, that's serious. Yes. And they're much more compliant in terms of your recommendations. This is my typical clinic patient, at least one a week. I wouldn't say one a day, but I do have some, I've had days where I've had 4 like this. Yeah, they're down to their last 7 nubs. We certainly, these are severe patients. Believe it or not, this is a Sjogren's syndrome patient. A lot of people think it doesn't affect the meibomian glands. Yeah, eventually it does. Those glands they burn out because they have to work so hard, so they eventually get affected too. You only need how many glands to be asymptomatic? 5.5. So you never give up on a patient. That's why meibography is so valuable to understanding. Contact lens wearing patients need twice as many meibomian glands yielding liquid secretions to be asymptomatic. which isn't surprising because you have to have enough to cover the cornea and to cover the lens. Oh, I didn't want this to build. It's going to take a moment. That's okay. So obstruction, blepharitis or biofilm, inflammation, and tear film. What I discovered over the last 20 some years is that when I treated only one element, I didn't get success all that often. So 24 years ago, I treated the tear film. I put artificial tears in, and I wondered why the patients didn't get better. Well, I wasn't touching the inflammation, the biofilm, or the obstruction. Then I said, okay, look, Restasis has come along. Let's try treating inflammation. And there were some it worked on, but the vast majority with evaporative needed something more. And that's treating the blepharitis, and that's treating the obstructed glands. Could be something as simple as omega fatty acids for inflammation, a lid scrub, and a hydrating compress. That could be all you need in a mild case with all their glands. If they're down to their last 5 glands, well, we're going to be talking about, yeah, we need to do a quick lid debridement. Let's get you in for thermal pulsation or an LLT or an IPL. For the blepharitis, we're going to do a blepharoexfoliation or BlephX. We're going to put you on doxycycline to start with and a steroid, then we'll move you to something else. And, you know, we're probably going to use something like Lumify or Brimonidine to make your eyes look better so you trust what I'm doing is working until your eyes can do well on their own. So you customize based on the severity, but you don't leave one of these elements out or your success will not be very high. And I had to learn that the hard way, but it's amazing when you start covering obit and you keep those glands from going into an obituary, just how well you'll do. And if it's aqueous deficient, that means the glands are functioning well. You're just treating ITV, inflammation and tear volume. Now here I'll be a little more aggressive. Like for example, I will put punctal plugs after treating inflammation in 90% of my aqueous deficient dry eye patients, but only 10% of my evaporative dry eye patients. So knowing what to use where makes a really big difference in this patient population. Autologous serum I rarely use in an evaporative dry eye, but I almost always use in aqueous deficient if it's Sjogren's related or something more severe. So have, you know, but don't miss an element. If you're just using artificial tears and not controlling the inflammation in a Sjogren's or an aqueous deficient form of dry eye, you just don't get anywhere. And keep in mind, there's more than just Restasis. There's Cequa, there's Clarity C. There's a lot of options to help you choose one of these drugs, either as we have up there as well. So I know that was quick, but it was meant to be. It was meant to just be a kind of a primer of, hey, we can do another webinar that gets into this and we get into the weeds next time. But this time I wanted to kind of just say in the COVID area, you can do a 3-minute exam. My exam is 3 minutes. I ask them a few directed questions or they do a questionnaire ahead of time. I check the closure of their eyelid. I look at osmolarity, mybography, and anything I can get off the OCULUS Keratograph. Then I set them at the slit lamp. I put in fluorescein. And with a Ratten filter, I could see conch staining, corneal staining, tear meniscus height. And prior to that, I expressed the meibomian glands before I put the fluorescein in. I expressed the glands, so I knew what was going on from a functional level to go along with their mybography. That literally is 2 minutes. Then I take about 2 or 3 minutes. I move back in my chair, so I'm a little further away from the patient, just out of safety for them and us. And I say, hey, here's the type of dry eye you have. I've got to address each of these elements, the obstruction, the blepharitis, the inflammation, and the tear film. Here's what I'd recommend. And patients love that. They get into it. They understand it right away. They say, that makes total sense. No wonder what I was on wasn't working so well. But you have to know the type of dry eye. You can do it in very few seconds. You have to do a few key tests. And Tony's going to take you through that in a really good way. He's going to take you through what you can do that you don't need a lot of equipment and things to do it, to be able to get at that assessment. But it's so critical then to your management. Let me take a few minutes before I pass it to him to go through that very important section to answer some of your questions.
Perfect. Thank you so much for that, Dr. Karpecki. All right, I do have a number of questions already submitted by audience members for you, but for those of you that have not yet submitted questions, please go ahead and enter a few of your questions now, or all of your questions, and we'll try and answer them now or after Giannotti's presentation. All right. So the first question that I have for you is kind of PPE related. And have you looked more into disposables or kind of one-time use products?
Good question, Carver, from whoever asked it. I do think that when possible, like gloves, yes, we don't have a choice. We have to glove and throw them out. And the patients appreciate seeing that. I think that's very important in how we do it. You know, the mask is good for the day. You know, I know sometimes we'll carry them another day or whatever, but that's, you know, disposable to a degree. As far as, you know, tonometer things along those lines, I think cleaning's still real critical in how you do it. You know, most of us don't use chlorhexidine like we're supposed to. That's the original FDA recommendation for cleaning tonometers, or that. Some of the newer ones, you know, like an Aura is a little better. They don't disperse as much tear film than some of the non-contacts of the past. So we can get around that approach to it. You know, I still just really make sure that we clean well. Alcohol's at a high concentration. We clean before the patient and then after the patient. Now, of course, that means twice, because before the next patient, you're cleaning again, but it just ensures that we don't miss anything. Now, you know, on the surgical side, we're doing, like, I'm in Kentucky, if I'm going to do, you know, a procedure like an SLT on a patient, we do have disposables there now, believe it or not, gonio prisms that we will use and then disperse, and they're not expensive. They're about $6, but I mean, it's still kind of expensive over time, but those do come into play here and there. But for most patients, it's just real adequate cleaning, PPE, disposable of the products we're using, but not so much of the equipment. And Tony might have some other answers too. He can add to that.
That makes perfect sense. Thank you so much for that answer. And I think we all feel, hey, if those $6 even you know, prevents one of our patients from, you know, going to the hospital, you know, that's a valuable thing to do. Kind of on a related note, do you have your patient, like, what PPE do you ask your patients to wear? I mean, masks obviously in a lot of practices are doing temperature checks at the door, but do you have them wear, like, you know, protective gloves or anything like that?
No, we don't. We leave them the option to. Masks are definitely required, and I think they're always going to be required for a number of years now in doctors' offices. There may be times when, you know, we're at herd, you know, vaccination levels, herd immunity, where, you know, you may not see them as much in restaurants and other places, but I think doctors' office is going to be the last place where that occurs. And so I think masking is an automatic. It's one of the few things that has been proven to work, you know, to kind of keep things down. We do tell patients how to wear their masks. So we estimate about 30% of our patients don't know how to wear their mask properly. And so it is important. My staff are good at it. The front desk, you know, Dr. Karpecki wants to see them, you know, they'll ask them to put them up properly. And if they do, most patients are very good about it. They just didn't know. And then they're fine. The odd time we'll get a patient who just doesn't want to, we'll say, you know, Dr. Karpecki won't see you. So they know that going into it, and they're usually pretty good when they get there. That's really the only thing we typically require. We actually did temperature checks until last week. Last week was our last day of doing it. We just were looking at some recent information and data that didn't support necessarily that the majority of patients do have a temperature. I still like the idea. I still think it gives patients kind of a sense of well-being that you're checking. Even if it catches one, like you said, Carver, that would be well worth it. So I'm not saying don't do that. That's just where the protocol is, but I do think that's a good one to continue for now. And I do think that you'd have to, you know, distance is important. Patients do stay in their car until they're called in. We call them on the number. They do get the questions if you had a fever, all these sort of things recently, been feeling ill, malaise. And I do recommend temperature check, even though that just recently has changed in our practice. I still think I'd do it in my other practice. Those are our typical protocols, but still is distance and time in the office. So for example, I used to do OCT and wait for the patient to come through the system, and my glaucoma patients and or visual field. Now what I do is I have the staff do that testing on a day I'm not even there, and then we set up a telehealth visit. I get the same 992 and 3 reimbursement with a 95 modifier, and I'm sitting at my desk. I'm looking at the patient in the Zoom or FaceTime, and I'm going through their OCT and their visual field and their pressures, and I'm saying, here's what I'm seeing. They love that. It's easier. They got more time than they ever would have got with me in the office. I get paid the same amount, and so we've taken those kind of steps in simple ways to do telemedicine. I don't do a lot of full exams in telemedicine, but if I get patients love not waiting another 40 minutes for me to go into a lane after getting their testing. Get their testing, they go home, and they get a telephone call or a video call to go through things. So we've taken some of those steps to help with managing patient volumes and distance.
Perfect. That was a fantastic response. The next kind of question that I have is kind of, have you changed your dry eye screenings kind of due to the, or like how you evaluate dry eye screenings due to the increased screen time? Specifically when it comes to the tear breakup time, do you follow the same guidelines of, if the tear breakup time is less than 10 seconds or less than 6 seconds? Have you changed that?
Yeah, that's a great question, because there are parts that we have really changed. For example, I used to have the patients come in and fill out an extensive questionnaire. That just meant too much time in the office. And this changed much more at the beginning. Maybe today we're a little okay to do it, but I still think that our flow's better by doing what we do now. So now they do a speed questionnaire before they come in, and we know the score by assessing it. And all I see is the score. Good enough. I'm going to ask them, when are your symptoms worse? Morning, night, all day? What's your worst symptom? Itching of the eyelids, whatever it might be. I just do a few directed questions. That is it now. And I look at their overall score. So that's one part. For tear breakup, I actually don't time it anymore. I don't wait 5, 10 seconds. I kind of glance at the end when I've already looked for staining, and I've looked for conj staining, and I've looked at the tear meniscus. I might look and say, yeah, it's still pretty quick breakup time, but I don't assess it based on that. The only time I would do that is if it's taken on the OCULUS Keratograph, because that gives you a wonderful assessment ahead of time. But I don't think you want to be doing that necessarily in your lane. Those days of pulling out stopwatch like we did in studies and time it, or sitting there and counting one. I think you're better served by either having the Oculus do it or just glancing at it and relying more on staining, conj, and cornea, relying more on expression, relying more on meibography, relying more on tear meniscus height. And I think you're going to get your answer with just that. And you know what? You get a 370-page document that says that's an ideal way to manage dry eye disease in the TFOS dues too. So I lean towards that approach a little bit more, as opposed to going the other way of discerning that. That being said, the question is excellent, because yes, we're seeing a lot more evaporative dry eye. We're seeing a lot more hordeola, a lot more chalazing than we've ever seen before. And it's the combination of the masks pushing air up into the eyes and the digital devices from all the Zoom calls that these people are on today.
Perfect. Thank you so much. I have one final question for you, and that is about evaluating meibomian gland dropout and how all the grading scales that this doctor's seemed to look at all just kind of have straight dropout and don't really seem to have torsion in them. How do you evaluate torsion when you're looking at it?
Yeah, I think I'm glad this doctor knows his stuff who asked this. This is really important. I think we get so caught up on, I agree with this question. We get caught up on just measuring volume of loss, which is important. But in a patient where they come in and they're complaining that they've been on too many Zoom calls and they're having dry eye issues and they can't blink their vision clear, and they have 90% of their glands, you'd think, well, they're doing fine, until you look at the effects on the glands. Are they twisted or torsional? Are they bifurcated at the end? Are they dilated, which is, a sign of stress? And we start looking at those, especially at the eyelid edge. That's where you start to see, the really significant effects that the patients are complaining about. So they feel validated. They say, okay, now I'm not in my mind. This is really happening. So, and you would miss that if you just looked at volume or level of atrophy. Now, the other extreme does apply. If you have the person who's really advanced, who has ocular rosacea, Sjogren's, and for a long time, or now the meibomian glands are atrophying significantly, then volume, plays a role, especially when you get above 70, 80%. You are, it's like looking at a glaucoma patient who has 0.9 CDs with extreme cupping. You got to manage that a lot more aggressively than if they came in with, 0.6 cups and showing some early nerve fiber layer loss. So you still have to look at atrophy, but I agree. For 90% of the patients, those other signs are probably more critical to the patient and their thinking and their management, because they're truly there supporting why they're having problems. Tortuosity, dilated ends, bifurcated, all those are really good signs to look for in meibography.
Perfect. Thank you so much, Dr. Karpecki. It's been great having you present. It's about time to have Dr. Giannotti present, so stick around, everyone. But I just wanted to thank you so much for your presentation. I've learned a lot.
Thank you. You've been a great host, Carver. Thank you.
All right. While we're getting kind of the next slide brought up, I'm not a doctor myself. I try to do my best to learn everything I can. What does that torsion indicate when you see it in a dry eye exam?
Sometimes it's anatomical, like, because I've seen patients who are young where you get a little of it, but that's rare. I think the majority of time it's just the glands have been obstructed, and that has caused pressure and caused changes to how the gland morphology is, and it does they bend or twist because of the stress they've had for a long period of time or the lack of functionality. Remember, it's our blink that each time we blink that pushes out the oils in a natural way to allow them to flow into function. And so patients who have an abnormal blink, patients who have that KB test that's positive or their eyelids don't touch in the right spot, patients who had cosmetic surgery, now all of a sudden that natural pumping that keeps them straight and flowing and doing what they need to do isn't happening, and the glands start to show tortuosity in particular. So it's probably related to poor functioning, and most of the poor functioning has to do with how the eyelids touch each other and blink.
Perfect. I'm just excited to have you here, and thank you so much, Dr. Karpecki.
It's been an honor. Good to see you as well, Tony. Good luck with everything. Glad to be sharing this with you, and thank you to all those who attended.
Great, Paul. Thank you very much. I always learn a tremendous amount from you whenever you speak here, and really appreciate that. Okay, so my name is Tony Giannotti. I practice in Scotts Valley, California. We're about 5 miles away from Santa Cruz, California, where I live. We're just over the hill from Silicon Valley, so we are a bedroom community. My disclosures. Okay, I'm being reimbursed by OCULUS, and I am not a dry eye guru. Okay, that's who Dr. Karpecki is. But hopefully, I can help you out a little bit and tell you about how I incorporated things in my practice. I've been here for over 40 years. We just celebrated 40 years at Scotts Valley last week. Full scope private practice. We see patients of all ranges, pediatrics to geriatrics. I probably see more Medicare patients than most of my colleagues. Bedroom community, suburbia, lots of high tech, both of commuting over the hill and also high tech here in Scotts Valley and in Santa Cruz. From geographically where we are, we're not in an area that's high desert. We're not in an area that you're inside with air conditioning or forced air heating. Most of the year there. It's not dry like Arizona or Texas or New Mexico. We don't have the seasonal allergies that you're going to have in other parts of the country, say the Southeast or the Midwest and things like that. So our dry eyes are not extremes, but it's a lot of tech use and device use, age-related types of things there. So why did I add dry eye to my practice? Obvious need to our patients improving dry eye care, but beyond just the slit lamp and staining on there. So I'm going to talk a little bit about what I do in my practice. So for all new patients and for existing patients, we use a speed questionnaire. I find that that's very valuable to get an idea about what somebody's problems are, what their symptoms are along the way. We all ask patients if they have dry eyes, and they say no. Okay, do your eyes itch, sting, water, burn, or feel gritty? Do you need to rub your eyes? You might elicit a little bit more from them, but with a speed questionnaire, as Dr. Karpecki said, it's great. You can get a number, and that tells you right away that this is something that you want to pursue. If you want to use OSDI, whatever one, I think that it's valuable to have something on there, and certainly it gets the patient thinking ahead of time. Aha, this is important to go ahead and talk about. This is important to answer about. So our workflow, we start with the speed questionnaire, all right, and then in our pretest, probably easily over 90% of my patients elect for supplemental testing, such as an OptiMap, screening OCT, and dry eye screening with Keratograph 5M. We do a lot of stuff, and let me explain how all this evolved. 8 years ago, when we got our OCT, to get our techs familiar with using it, we started using a screening program on there, and we ended up not charging the patient extra, and then we just made it part of our pretest, just add that along there. And the same thing happened when we got our Keratograph about 4 years ago. And in order to get our techs up to speed and familiar and comfortable using it, we started doing dry eye screening on all our adult patients, and then the information we got from there was valuable. If signs and symptoms warrant it, the patient's going to return for a medical visit, typically level 3 with anterior segment photos, and we'll probably do about 25 to 30 of those a month. So here's the screen. This one's kind of busy on here. Mine doesn't. When I bring this up, the screening picture on here, it doesn't have all these on here. I'm going to concentrate on, in the screening exam, 3 different things: the tear meniscus height, the non-invasive tear breakup time, and the redness. And I think that showing it to a patient and gives them a lot of information, gives me a lot of information that goes on. So in measuring the tear meniscus, we measure it, we show the patient, yeah, you've got an adequate amount of tears, you've got not enough, or you've got an excessive amount of tears there, all right? And then helps us make that decision, okay, which way are we going, evaporative dry eye, or is it something, aqueous deficiency along the way. The next thing we look at is the non-invasive tear breakup time on here. And this is great. I explained to a patient, okay, you spill water and the water beads up on the table. We don't want that to happen. We want this nice, even, smooth film there. So in a perfect world, all of this is green, saying it takes a long time for your tears to dry out on the eyes. When we have obviously this orange, red, or yellow on here, and we explained to them, now your tears are drying out in 4 or 5 seconds. This is why your eyes are uncomfortable. This is why you're having some difficulty here. So we want to work on improving that over time. We certainly can measure the redness of the eye here, and be able to say, hey, this is normal, or this is not normal. And this is, you look in the mirror and your eyes don't look good. Well, yeah, they really don't look good when you look at them this close. And then providing these pictures and showing them over time, you can see they're able to see their progression and be able to see the improvement they have on along the way. So those are the 3 things that we use in our dry eye screening with the patient. And so if we decide that yes, signs and symptoms justify it, we're going to bring them back for that medical visit and do the diagnosis on there, and add some more things to it along the way. So I'm going to be repeating these 3, but I'm also going to be looking specifically at the lid margin on here. This happens to be a very healthy one here. Dr. Karpecki showed us, beautiful signs of blepharitis on there. So we see, either the scaly or the collarettes on there, or you can see lid wiper epitheliopathy, or whatever things that you want to show here as far as imaging on here. I use this. I don't have a slit lamp camera, but this works great for my anterior segment imaging that I like to have. All right. Another thing that's very important is the meibomian gland imaging and expressing. Okay, when I've got a patient who's at the slit lamp there, I'm going to go ahead and manually express the gland very, very quick. And hopefully I'm going to see this nice golden fluid that's there. If I get this white pasty stuff like goat cheese, that's no bueno. And I let the patient know, and also let them know that it looks really, really gross at 15, 20 times magnification in the microscope there. And then we're going to add, obviously, fluorescein staining on there. I also use lissamine green staining. You can actually put the 2 strips together with 1 drop, and you can actually, when you're good at it, and you practice enough, you can get both of those with 1 swipe. You don't have to do it twice. But be able to show them with the Keratograph the extent of staining that they have, and be able to show the progression as it heals. And you can show them their tear breakup time. You can show them mapped out fingerprint dystrophy on here. You can document abrasions and other irritations of the eyes, and corneal staining and conjunctival staining on there. So I certainly find that is a valuable part of the whole program that's there. So, as far as what I do with my treatment on there, there's certain things that I'll use in the practice. Almost all of us use lid wash, Bruder mask, omega-3s, hypochlorous acid, ointment at night, different artificial tears, Restasis, Xiidra, Lotamax, T-Triol, punctal plugs. And then I reach a point where, maybe I need to send a patient to somebody smarter than me. And I'm fortunate that I've got a really good corneal specialist who's just over the hill, about 20 minutes away. I've worked with him for about 25 years. And when I've got somebody who's a real challenge, I go ahead and send them there. I don't see this, my day isn't spent seeing the challenging patients that Dr. Karpecki is seeing on here. And because of that, I'm also, I've been doing this a long time, and I don't want to buy any more equipment. I'd like to be able to have everything paid off before I retire. So I don't have LipiFlow or IPL and things like that. So I have a colleague of mine who's got LipiFlow. If I decide that thermal expression makes sense, I go ahead and send them off to him to go ahead and have that done. So COVID, this time a year ago, all of us were shut down for approximately, 8 weeks or some longer on there. So obviously all dry eye screening stopped. We returned to practice about the middle of May, had a couple weeks of a 50% schedule, and then back to a quote unquote full schedule. Which is probably 2/3 or 3/4 of what it was pre-COVID on there. People still being cautious about coming out. We want to be very like everybody, we're being very conscious about how quickly we move patients through the office, the number of patients in the office, limiting our exposure to them and their exposure to us. So a lot of the pre-test things that we normally do, we've got about 11, 12 different tests that we normally do with our pre-test patients. We eliminated a lot of them along the way, and one of them was the routine dry eye screening. We would go ahead and continue to use the Keratograph for our existing dry eye patients on there for the treatment, but otherwise we weren't doing the screening. So in the fall, we resumed the routine screening with all new patients, and at the beginning of the year, we've returned to the screening of all adult patients along there. So has the care for my patients improved since I got the Keratograph? Absolutely. I've got a much better perspective about what goes on and what happens here. I get a great idea, much better idea about what is the cause of the disease, and then is it evaporative? Is it due to aqueous deficiency? And then I can then zero in on much more targeted treatment. Is it infection? Is it inflammation? Is it allergy? Is it eyelid disease? Is it side effect of medication, systemic disease, and the environment there? All of us go through those and can be much more focused. And I get improved patient compliance because they can see, aha, look at all those collarettes and things like that off my lids. They're gone. Look how much brighter my eye is. It's not as red as it was before. Look how there's no staining of the eyes along the way. So they become very, very compliant with their treatment on there. So a little perspective on kind of return on income here. And again, we don't do LipiFlow, we don't do BlephX, we don't do IPL and things like that, where you're getting large reimbursement for patients, that's out of pocket, and that's just because we don't see enough of things that really justify that to do that. So different instruments that we have in our office. We got an OptiMap, and the OptiMap makes money. An OCT. An OCT doesn't make money, but it's a tool you really have to have for patient care. Those of us that were started in practice before Al Gore invented the internet, we had to learn how these instruments work. What's an OCT? Once I got it in the office 8 years ago, it's like, and started to use it, saw the value of it. Says, this is fantastic. There's no way I would practice without it. So at best you can break even, and then fortunately you reach a point where it's paid off, which is great. The Keratograph can make you money, but you got to use it. All right. I've got a couple of colleagues that have this instrument, and it's there, and they bring it out for special occasions. It's a great topographer, but they're only bringing it out for specific things. And I think that using it as a screening tool on every patient who comes in is really, really valuable. If you want to treat dry eye, it's a tool that greatly improves the quality of care. I joke that it's kind of like the gateway drug to dry eye care, because it is, by using it as a screening tool and just incorporating that as part of our pre-test on there, it really opens up a lot of dialogue and seeing a lot more dry eye patients because of that. It'll demonstrate the need for additional treatments for the patients. It documents positive responses from these treatments. We charge a level 3 office visit and anterior segment photo. A combination of those two pays out here about $125 on Medicare. You do one of those a week, that's going to take care of your monthly payment on this for the instrument there. So I hope that this was helpful and give you an idea about how I integrated in my office there. If you have any, if you want to contact me, if you have any questions, certainly here's my contact information: tgiannotti@pacbell.net. Oculus can certainly tie you in also. Again, I'm not the guru, but I really enjoy using this instrument. I'm glad that I made it part of our arsenal here. Carver, you got anything for me?
I do. First of all, just thank you so much for that presentation. Even if, as you say, you are kind of more of the standard doctor that's treating dry eye. I still definitely learn things by watching your presentation. So thank you so much for that. And I hope everyone else enjoyed it as well. At this point, thank you everyone for attending. If you have questions, we have some time to answer those. So go ahead and put those into chat and we'll do our best to answer them with the time we have remaining. All right. So the first question I had is actually about the supplemental testing, and asking how you get so many of your patients to do the supplemental testing. I have a question here that you're basically saying that the supplemental testing rate in their office is a lot lower.
That's a great question. My staff, tells every patient. First of all, we get great dialogue from Optos. They're very good. If you have it, talk to and you're having trouble with that, talk to Optos. Talk to them. They can give you great dialogue. That's where we learned about that. But every patient in my office, we're either getting an Optimap or they're going to dilate their eyes, and nobody likes to have their eyes dilated. For kids, what we would do is we would reduce the fee for that to about half of what we would do for an adult. So for a family of 5, it didn't cost them a fortune to go ahead and do that. And then every once in a while, I'll just say, here, all right, look. I'm going to do it. It's going to be on my dime this time, and next time we're going to dilate their eyes. And they remember how miserable it was when they dilated their eyes, and they saw this picture. I go over the picture with them and everything that it tells me and what it reveals to me, and they get really impressed. Some people just pull up the screen and say everything's good, and then they move on. But if you have the opportunity to spend a little time, explain that, hey, this is blood vessels. This is what's normal. This is what's not. Yours is great. Show them a little bit about some things along the way. It makes a big difference, and they really like to be able to see those pictures and compare them from year to year.
Perfect. Thank you so much for that in-depth answer. You mentioned that you have been friends with that doctor that you referred to for a long time, like 25 years or something like that. How did you really decide to refer your patients out, and how did you develop that relationship to kind of refer those patients out?
Well, that's a great question. I know my comfort level. I know what I want to do, and if there are times where I recognize, I'm in over my head, and I know some really smart people, and they're going to be able to answer this. And sometimes they're going to get a lot of times they come back and say, we don't know what's going on either. Here's what we're going to try to take care of that. This particular individual, Mark Mandel, refractive surgeon in Santa Clara and Hayward, California. I've known Mark for over 25 years, and just wonderful guy, and we've just had a great relation. Anytime I've had a question, I can give him a call. He takes really weird things from people all over the country and all over the world coming in to see him, and I know that my patients are going to be taken well care of. I've got a colleague of mine who's got a LipiFlow, and so I don't have that instrument here, but I know that I can refer them to their practice, and they're going to be well taken care of there.
Great. That's a fantastic answer. I have one or two more questions for you, and then I think we'll call it. The first question is about the SPEED questionnaire. And do you kind of categorize the results into kind of a mild, moderate, medium, severe, or like what kind of distinguishing scores do you use to separate the normal results from the abnormal responses to the SPEED questionnaire?
Yeah, I like what I like what Paul says. Is I just get a number and move on. Scott Schachter, is anything 5 or 6 or above, he's going to go ahead and recommend a recommended more in-depth visit on there, and that's how I go. I don't want to overanalyze it. Keep it simple.
Perfect. All right, and I have one last question for you before we end tonight. Do you have a preferred brand of fluorescein that you use when doing fluorescein testing?
No, anything I can get my hands on for a while. Now I mean you can get. I don't have a preferred brand fluorescein on there.
All right. Well, perfect. Thank you so much. I really enjoyed both your and Dr. Karpecki's presentation tonight, and I think everyone learned a lot. So on behalf of Oculus, thank you so much, everyone, for attending, and thank you so much, Tony.
Thank you for having me.
All right. On behalf of Oculus, good night, everyone.